Hi everybody, and welcome. This week we're going to review the last two FTAGs, FTAG 425 and FTAG 431. And in the previous FTAGs we reviewed about the roles of a consulting pharmacist. We also reviewed about unnecessary medications. This part of the FTAGs focuses a lot more on about patient safety and a lot about the distribution roles and safety that's needed to be provided by a long-term care pharmacy. The first one we're going to look at is FTAG 425, and just a couple things. This lecture is not going to be a super long lecture, just because a lot of this stuff is basic relevance that you should know from pharmacy law in terms of labeling, but we're going to put out those key points. And then the final thing we're going to do is review some sample reports that go along with this and some sample reports that are required by the consulting pharmacist. I did post a couple other additional materials online reviewing these FTAGs for you to read on your own. Hopefully you've done that already. And then the final thing I did is a nice chart that looks at all the different FTAGs that are affected by pharmacy. Because next week in our live chat session, we're going to do a lecture and do a case discussion on the quality indicators for long-term care. So, and like the other final thing is there was some material this week to talk about cost containment and also about technology. We'll integrate those between next week's chat session and talking about the survey process, which I thought would be more appropriate. So if we look at FTAG 425, the facility, is required to do the following things. Key one is provide routine and emergency medications to its residents so that if something is needed, it has to be given in an adequate period of time, and we'll talk about what actually means emergency. They also need to provide pharmaceutical services, and those are things such as dispensing and administering of all medications to the resident. It is their requirement by being a nursing home that takes Medicare patients and Medicaid patients. The other thing is they have to, and this is, I said before, one of the only places in the law, in anything besides now that we have MTM, that it says that it has to be a consulting pharmacist, has to provide services to the facility. Like in MTM, the law says it may be a pharmacist. So this is the only law that we actually have in the books that says that. And the facility may permit unlicensed personnel to administer medications if the state law permits. So here in the state of Pennsylvania, we can have registered nurses and licensed practice nurses to be able to administer pharmaceutical services under skilled nursing care. When we talk about personal care homes in a couple of weeks, we'll talk about those people don't have to be a licensed nurse. Those people have to go through a medication administration training, but usually their only requirement is a high school diploma. A couple things to focus on. One about the provision of medications is that the key one, when a surveyor comes on site, they look at, are the medications there available on site at the appropriate time that the resident needs them. And one of the things it says in FTAG 425, and I'll read it, is the pharmacist is responsible for helping the facility obtain and maintain timely and appropriate pharmaceutical services that support the residents' healthcare needs. These are consistent with the current standards of practice that meet the state and federal requirements. So sometimes, as I said before, not Pennsylvania necessarily, but some other states actually require the pharmacist and the dispensing pharmacy to be separate. Here in Pennsylvania, that's not needed. And the reason why I bring that up is even though maybe you are not employed by the dispensing pharmacy, or perhaps a resident is not using your pharmacy but using, say, mail order or something else, it's still the requirement of that consulting pharmacist to make sure that these services are being met. There's contracts that will be signed between the dispensing pharmacy and the nursing home. There's contracts that have to be signed between the consulting pharmacist and the nursing home, showing that these services will be done. And under FTAG 425, the services that they discuss is how to acquire medications, how to receive them. Most nursing homes have delivery, and like I said, a lot of times nursing homes have twice a day delivery. Some nursing homes have gotten to the high technology to be similar to hospitals, that they'll have medication electronic picking machines, such as Pyxis machines, Omnicell machines. The other thing is they have to have who's the licensed personnel to be able to do this. And then the other key one is how do they get rid of it, and labeling and storage of the medications. Factors that may help determine timeliness and guide procedures for acquisition include the availability of the meds to enable continuity of care for anticipation of admission or transfer, condition of the resident on how severe, the category of the medication that may warrant that it's an emergency supply, and that when it says that a medication is going to be given at that time, it has to be given within that reasonable amount of time. And so making sure med passes are done in an appropriate manner. So the first thing is, how does a nursing home have a mechanism to identify and prioritize the communication of a new medication order and a new admit? So, all nursing homes have different systems. In the prior days, a lot of those nursing homes had where they just faxed the orders to the pharmacy, and the pharmacy had a procedure that unless it was an emergency medication, that medication would be given upon the next delivery. And so, for example, somebody was starting an antidepressant. We all know that antidepressants don't take several weeks to kick in. Is that warranted to be given as soon as the order is written? No, that medication can be given within the next time of the next delivery. And like I said, most deliveries are either morning or evening. All right. Does the facility staff know to tell the pharmacy whether a readmit needs supply of their medications or resent? So if you get an admission or somebody comes back, maybe they don't need all their medications filled because they're not due to be filled, but how do they communicate? One of the ways communication is done in the nursing home is a lot of nursing homes have electronic MAR systems. A lot of homes now have some type of physician order entry system, so that in real time the order will be sent to the pharmacy and put on their electronic MAR. The other thing is some nursing homes still do the good old faxing system with the paper physician orders. The other thing is what deems to be an emergency medication. And so, obviously medications that may need to be done immediately. Somebody has developed a severe infection. Somebody has fallen and is in severe pain. Somebody is suffering acute conditions. And so, in the ways to address those is most nursing homes has some type of emergency drug supply there at the facility. So, the key thing is if there is an emergency drug supply there after hours, one of the roles and responsibilities of the pharmacist and the pharmacy is to make sure that those kits are up to date and make sure that those kits have no expired meds in them. Do the nurse facility prompt or encourage physicians and nurse practitioners to utilize the medication in the emergency kit? So one of the things that the consulting pharmacist may oversee is what is deemed necessary, look at trends of what's being ordered that needs to be in that emergency drug supply. The other thing is, depending upon the state might also have rules and regulations, how specific medication delivery or administration timeframes. And like I said, here in the state of Pennsylvania, most of the time what's considered regard to timeliness is that a medication can start upon the next delivery, unless it falls into that category that I said about emergency. And like I said, most of the times, if a medication, for example, is supposed to be given at the 8 a.m. med pass, it usually has to be given within that 2-hour window of that med pass. So, a couple things. The pharmacist is responsible for helping the facility to obtain and maintain timely and appropriate pharmaceutical services. And I read this earlier. The consulting pharmacist's responsibilities in collaboration with the facility may include coordinating these services, Also coordinating how multiple pharmacies deliver the medications. And you can have numerous different other type of services that are delivering medications, such as infusion providers, hospice patients, and another one is prescription drug plans. So just because, say, in the community world, if a medication needs prior authorization, what happens? Well, the patient usually can't afford the medication, and so the patient will wait until that medication is approved and do that. In a nursing home, it's a little bit different. If that doctor writes an order for a drug, so say they write an order for a drug for like Zyvox, all right, antibiotic, which sometimes may require prior authorization. Well, the doctor has deemed that that is necessary for that drug to be started. However, the insurance company may say, you know what, it requires a prior authorization. So what happens? You're at an impasse there because if the nursing home does not administer the medication, regardless that the insurance can't pay for it, they're out of compliance. The patient may not be able to afford it, but because there's an active order. So, real simple couple things. If it's an emergency drug situation, you, the consulting pharmacist, or the pharmacist within the staff of the dispensing pharmacy, need to look at, are there alternatives that they can recommend that will be covered? If there isn't, is there a way to fast track this prior authorization process? If there's not a way to fast track the prior authorization process, and you have to work with the physician and the nurses at that facility to see if you can get what's called a hold order, that the physician says, please hold this order until prior authorization, and so that the order is no longer active. The other thing is some nursing homes will have policies that they will cover maybe the first 3 to 4 days of a drug, and also in their contract agreement, agree to pay it, all right, if say it wouldn't be covered down the road. So once again, you know, in a long-term care facility, because these people are in a nursing home, but we're dealing with PBM providers, and if something is non-formulary, something's not covered, it's a requirement, or a patient can't afford it, you are playing the role of, just like a community pharmacist, helping that patient obtain that medication. So, as I said before, the procedures. All nursing homes have to have policies and procedures, and usually there's templates you can get. The American Society of Consulting Pharmacists has templates of contracts, but those procedures have to include how does a nursing home acquire the medication, so how do they order medication to the pharmacy, how do they receive it, the delivery process, what is the dispensing delivery system. So, for example, is it a bubble package system? Is it a multi-dose pack system? Is it a unit dose system? What's the cart system? Most nursing homes will have carts that are leased to them by the nursing home pharmacy. What is the administration process? Are they using paper medication administration records? Are they using electronic MAR records? What does the rules say for labeling and storage, disposal, and who is allowed within the nursing home to administer and handle medications, from the receiving of them to the administration of them to the elimination of them. As I said before, first you need them, policies and procedures, and you need to make sure that all the staff is educated by them. When we talk about the survey process, when the surveyors come in, they may quiz different staff. How do you know about these policies and procedures? The other thing that's required is at least yearly that both the consulting pharmacist and the director of pharmacy must review these policies and procedures with the director of nursing, with the medical director, see if they need to be updated, and making sure that they are signed and updated and active. So, what are some examples that go in policy procedures? So, for example, the emergency kits. So, one of the things is, what types of medications are in the emergency kit? What's the supply? Where are they located within the facility? Who's allowed to access the supply? You don't want every nurse, so usually it's the director of nursing or the charge nurse that does that. How is the record keeping of replenishing the supply? when we're using like these electronic dispensing systems, usually they have some type of communication technology to feed back to the pharmacy so they can warrant things such as expiration dates, things such as low supply. There are some facilities that still use just a good old plain tackle box, and that one a couple things with that tackle box is the supplies is in there, and usually there's an exchange of the emergency drug box when a delivery driver shows up, and if there is an exchange when the delivery driver brings a new emergency drug box, it usually has a locked has like a disposable lock on it, and if that and sometimes we'll use color coding. So if it is a replenished emergency drug and has never been used, it may have like a yellow lock on it. If there's been something used out of it, but they'll be relocked, there may be a red lock on it. So warning that when the driver shows up, they see the emergency drug supply, and it has a red lock. That means they need to exchange it. They'll take it back to the pharmacy. The pharmacy will review of what has been taken out of there, and also periodically it's a requirement of the pharmacy, whether it's the pharmacist or the pharmacy tech, to review what medications might be expiring. One of the first things that, just like a surveyor comes into community pharmacy is, or state inspectors, the first thing they go is to the emergency drug box and to make sure that they are available, look at the policy and procedures of them, and are there any expired meds within that? Because a lot of times some facilities will say, or I've seen some pharmacies will say, because they don't want to have to be called in for emergency supplies, is they'll put a ton of stuff in an emergency drug box system, and that's okay. But once again, if you're going to put a ton of stuff there, you better have a policy to check if there's expiration dates, making sure nothing is expired and making sure that it's appropriate. Also, things such as recalls, drug recalls, that there's a system to be able to do that. The other thing within the policy and procedures is talks about, the procedures for administration of IV therapy. One of the things at a skilled nursing facility is that they can administer IV medications. So there has to be in the policy and procedures how, you know, staff are trained, how they are determined who's appropriate staff to help with IV medications, and also what is the procedures for, is there any sterile compounding that goes actually right on the site? How do we do dosage calculations? How do we use IV pump use and flushing procedures? A lot of times too, the pharmacy that is dispensing probably will have an IV charge nurse that works for the pharmacy that will come in and do in-services, or they'll contract that out. And sometimes they'll contract out with IV nursing. Most nursing facilities don't internally. They'll have different people that know how to start an IV, but they'll actually contract out with IV nursing services that will come in and start that IV for them if they don't have appropriate staff to do so. Then the other thing is, for IVs, there are rules within, and one of the things in FTAG 431, a lot of the rules in FTAG 431 talk about labeling. So, for example, what needs to be going on an IV label, the name of the medication, how much volume of it. So if it's like vancomycin 1 gram, vancomycin 1 gram is usually in 250 mLs of IV saline, normal saline, so that needs to be put onto the label. The resin's name. The other thing is determining the infusion rate. So let's use an example. If it's a gentamicin IV, that infusion rate is usually over 30 minutes. If it is a vancomycin IV, that infusion rate is usually over 60 minutes. So making sure that we know that. The name and quantity of each additive, what's the drug in it, what's the strength of it, and what is the diluent that it is in. The name and preparation should also have expiration date of the antibiotic. Dates and times of administration. Sometimes if it's like, the person's getting a course of maybe 7 days, and so maybe sometimes the antibiotics will be sent all. Sometimes they'll do it on a daily basis, but say that they're getting something Q6, well, 4 bags will be sent, and so the label will say bag 1 of 4, 2 of 4, so the nursing home can keep track of that. The other thing too is if it's something like pre-mixed IV antibiotics, so a lot of times those get used in facilities, so there's not waste. What basically will happen is it's a closed system that the nurses can release the dry powder that goes into the IV bag, and when that's there, there should be some type of sticker system for them to date when the mixture occurred so that they can assess when the drug will expire. The other thing is there should be a mechanism to show that a facility has received the medication from the dispensing pharmacy. So just like when somebody picks a prescription up at the community pharmacy, that there is a signing process. A lot of pharmacies have gone to electronic signatures with iPads. Um, the other thing is how will it be reconciled with the prescriber's order. So like if they do receive it, before they administer it, they have to verify that that's the right drug, the labeling's appropriate to what the physician wrote on the order, and then also make sure that it's deemed, that it's stored appropriately. Where does it need to be stored? Into a med room. Med rooms need to be locked, or they need to be put in the cart, and the cart has to be locked. And so, those are all deemed. If it's a controlled medication, usually only certain nurses can handle controlled medications, and those have to be locked. The other big one that they talk about in FTAG 425 is disposable medications. If a medication is expired or a medication has been discontinued, there has to be a timely process of how that medication is disposed of. And so usually there has to be that, say, for example, somebody was on amlodipine 10 milligrams and they have a 30-day bubble pack in their cart to dispense that drug, and say the doctor discontinues today. All right, that the nursing home has to take the drug out of the cart and they will put it in an area for disposal. Most nursing home pharmacies will take back disposable drugs. The only ones that are not allowed to take back are controlled medications. And so what they'll do is they'll take back the disposable drug. Now, when they take back the disposable drug, they are not allowed to restock it just like any community pharmacy can. And so most nursing home pharmacies will have some type of disposal system. Like, for example, there's a company in Pittsburgh, I think it's a national company, they're called Stericycle. And so usually what they'll do is they'll send those to that company, and they'll incinerate and remove that so that there's no flushing of these drugs down the toilet. If they are controlled medications, those usually have to be destroyed on site, and usually there's a policy procedures that those are destroyed with 2 witnesses with documentation. And that documentation of disposal needs to show that this drug was given back to the pharmacy or to the appropriate people and their signs and signatures. If it's a unit dose system, that if it's unit dose and individually packaged still in the manufacturer package system, sometimes that stuff can be restocked and credited, and so there should be a policy procedure for that to occur also. As I said before, the facility must employ or obtain the services of a licensed pharmacist who does the following: establish a system of records of receipt of disposal of all controlled medications to enable an accurate reconciliation. Determine that medication records are in order, that the account of all controlled medications is maintained and periodically reconciled. So I said before, these controlled medications have to be destroyed on site, but it's up to the pharmacy to help oversee this procedure that this is occurring. Let's talk about FTAG 431. As I said before, both FTAG 425 and FTAG 431 are not the most exciting procedures, but they're necessary for the nursing home to function, to make sure they are ensuring the safety of the patient. So the two in FTAG 431 that we really focus on is storage, labeling, and controlled med regulations. Labeling, all right? Medications and any type of biologicals used in the facility must be labeled in accordance with the currently accepted professional principles, including the appropriate accessory, cautionary instructions, expiration date when applicable. So the key thing with this one is if it's a medication for a resident, it's got to have their name on it. If it's a medication for the resident, there has to be a place for the directions, the drug, the expiration date of the drug, the lot number of the drug. And so if it's dispensed in a bubble packaging system where it's repackaged, there needs to be appropriateness of when this will expire. The labeling of it, has to pretty much look like a community pharmacy labeling for that. If, for example, you're dispensing an eye drop or a meter dose inhaler, those will come in a box, and there will also be the device. Well, the box may have the prescription label, but that device, whether it's an eye drop or whether it's an inhaler, has to have some type of sticker system that resident's name on it, their room number, and their location. Storage. In accordance with state and federal laws, the facility must store all medications in locked compartments, so there's usually a locked med room. That med room has to have appropriate temperature controls, and only authorized personnel are allowed in it. The same with the medication cart that's usually used to wheel around to the individual rooms to dispense the medications. The other thing is that whether it's the consulting pharmacist doing it or whether it is a pharmacy tech to assist them, that med room has to be inspected periodically by pharmacy. And that med room is looking at things such as appropriate documentation, looking at expiration dates that might be in the cart. Are there discontinued meds in the med room that shouldn't be there anymore? They should have been disposed of, or in the cart. And then checking things such as temperature of the refrigerator, temperature of the room itself. Controlled meds. The facility must provide separately locked, permanently fixed compartments for storage of controlled medications, and those have to be packaged appropriately. So, for example, most med carts have a separate area where the medications for controlled are stored. So most carts actually have a locked area, and that's a second lock key, and only certain staff have that key. The other thing too is these medications, if they are refrigerator controlled meds, there actually has to be some type of lockbox that cannot be picked up out of the fridge, that it has to be permanently affixed within the refrigerator for it to be locked up. And once again, there has to be appropriate documentation. Most facilities have a type of dispensing system where every time a controlled med is given, there's a sign out of it, and there's also what's called a controlled med count. So most of the time the controlled meds are counted per shift between each shifts to make sure that what was given and what is still there is there. So it's a perpetual inventory checking that a lot of pharmacies do also internally. Some other labeling points: the facility ensures the label in response to the order changes is accurate and consistent with state requirements. Nurses cannot relabel or alter a label. So what happens, for example, say that an order changes, that something goes from once a day to twice a day, and maybe according to PBM policy, it's refilled too soon. Well, usually what has to happen is there's usually stickers that will get stickered over the directions of the label and say, please refer to new directions per EMAR chart or medication administration record chart. So that can be used temporarily to be able to do that. For meds designed for multiple administrations, such as inhalers, eye drops, the other thing that has to, and this doesn't always happen in the community pharmacy, there's a lot of times some laziness, is that it has to say on the label, is it by mouth, for the eye? If it is for the eye, exactly what eye? Is it for rectally, topically? Those have to be written exactly on the label. You cannot use just as directed also on a label. There has to be specific directions for that. And for also PRN medications, it has to say exactly what is it for, as needed for what, and that has to be documented appropriately. Kind of already talked about the appropriate labeling for IV labels, so we'll kind of skip that. Some nursing home facilities will actually, instead of having individual OTCs items for each resident, they'll use bulk containers, and that's okay. However, if they do use a bulk container, that there has to be a label on that bulk container for every resident taking that. Some states may have a way to have that near that container, and if it is from the original manufacturer, that has to have the medication name, strength, quantity, and directions. All right. My personal opinion, I see a lot of times nursing homes get cited when they use bulk containers because they don't update their labeling, or there's people that says they should be taking this and they're no longer taking it. It's been discontinued. So my personal opinion is most OTCs are particularly cheap compared to other medications, and you should have individual orders for each OTC medication. That's just my personal opinion. That's always been my recommendation when I deal with facilities, that they should have individual OTC medications. The other thing too is access to the medications. Is keys. We now are into like the fingerprint system. All right, and then the other thing too, that is during a med pass, the medications have to be under direct observation of the person administering them, so they cannot leave the med cart. One of the things that happens, during the time period when maybe the state doesn't show up, people get lazy, and for example, say there's an emergency, they have to leave or go somewhere. They can't just leave the med cart laying out there. They can't leave the med room open, because there's possibility there's access to it from a theft standpoint, from a resident accidentally getting in there taking medications they may not are not supposed to take, and so the med pass card cannot be there. Some facilities do allow residents that are competent to self-administer, and there is usually a procedure to evaluate whether or not that person can. So, for example, maybe they have a sublingual nitroglycerin, maybe they have a PRN albuterol inhaler. Once they should have some type of documentation system showing that this person has the skills to do self-administration. But if they do have those skills, if it's kept in the room, it has to be kept in some type of lock system in the room, and that resident is the only one able to access that besides maybe nursing. The other key thing about when we look at storage, that has to be periodically checked is the temperature of the fridge, the humidity of the room, making sure that that room meets manufacturer specifications, state requirements for the storage of the medications. So, what are some ways that a pharmacist helps them prepare? You develop procedures and guidance in regards to 425 and 431. You also, look at, policy procedures also can address our prior FTAG we talked about as FTAG425. So one of the things that happens is, besides doing your irregularities about clinical, you also have to look at your irregularities about, storage, appropriate administration, are allergies being documented, and so there has to be a way to be able to evaluate that. And that's what I provided to you as ancillary sample reports, that usually on a monthly basis that there should be medroom inspections from the pharmacy. On at least maybe on a quarterly basis, there should be med pass observations. All right, we're going to talk about next week about quality indicators, but the quality indicators will play a role in helping you prepare in evaluating what the facilities having any pharmacy issues, and we'll talk about the MDS, which is a form system that's derived from these quality indicators. And they do help us with pharmacy in preparing, are there any irregularities related to medications. When, for example, when a new medication is ordered, all right, there usually is some type of formal process of what needs to be required. These are the simple things we do every day when we fill a medication, but we need to know exactly what the medication is, what the strength is, what's the dosage form, what's the frequencies. If it's a scheduled, is there a specific time? Most nursing facilities will have set times, and so when you are starting to work for that facility, you want to know what those set times are. So, for example, if it's BID, that doesn't necessarily mean Q12. Some nursing facilities, BID means 8 and 4. And so you need to know those times, because the other thing we have to evaluate is that medication be given the right time. So, for example, if levothyroxine is given at 8 a.m. and we know that 8 a.m. is breakfast time, well, that's not an appropriate time that medication should be administered. Or if Fosamax is, dosed QD, and QD is 8 a.m., well, there might need to be a separate time. The other thing, as I told you before, is that if it's PRN, there has to be specific, instructions of what that is. Another thing is, for example, you cannot have an order in a nursing facility that says take 1 or 2 tablets as needed for pain. if that is an order that the physician feels it's necessary, there has to be two separate orders. There has to be take one tablet as needed for, say, moderate pain, and take two tablets as needed for severe pain. And how would they determine that? Well, then the nursing facility should have some type of pain scale to assess the difference between moderate and severe pain. The other thing sometimes you'll see on orders of is check pulse before administering the medication. One of the things that has to be done is that documentation of whatever checking is going on has to be also on the medication chart. And so one of the things is we check, charting. That's one of our other responsibilities. Pharmacy is it necessary for that drug to have, for example, a pulse checked every time? Because maybe the compliance rate of nursing checking that, or at least documenting that, is not appropriate. And so you, the pharmacist, besides dispensing the drug, or you, the consulting pharmacist, besides looking for clinical irregularities, you got to look for labeling and dispensing irregularities, for documentation purposes. The other thing is that the facility should also know what to monitor. All right, so if it's a medication, what to monitor, when to monitor it, and so that's one of the roles of us to be able to do that. We already talked about the needs for necessary meds and documenting that. So, like I said, these kind of the 425, the 431, and the 329 kind of go right into play. A good way to make sure everybody's on board is to regularly do some educational in-services with the staff, to let them know of, for example, how do you reorder medication from the pharmacy, who to contact for billing questions, how to contact the pharmacy after hours. And so most of the times, for example, if you take care of a nursing home, a new nursing home, or you have new staff, there should be a way to orient that. Usually there should be at each nursing station a list of who to contact at the pharmacy, how to do certain things to make sure everybody's on the same page. The other thing too is educational in-services also may help you from clinically. So, for example, say that I see that there's a lot of falls documented, and I feel that there's certain people are on medications that might be warning falls. A lot of times, what I'll do is I'll do an in-service about medications related to falls. Or if I see a trend of overusage of, say, hypnotics, a lot of times I'll do educational in-services to the nurses about that. And the reason why I do that is because nursing has a lot of power. They have the power of the pen. They're the ones seeing these residents every day. And when a doctor comes in, they're saying, hey, you know what, Mrs. So-and-so is not sleeping. Well, maybe that's the evening nurse that says Mrs. So-and-so is not sleeping and says the hypnotic, but the day nurse has documented in the chart that, this person takes naps all the time. And then the other thing is they fell 3 times during the day last week because they were groggy. So, having nursing in services is a great way to share with nurses about how medications can help, but they can also cause problems. And I've seen many times when I've done these in services, improvement of falls and reduction of medications that may cause falls. The other thing that you might do in educational in-services with nursing staff is, appropriate usage of IV medications, how to dispose of them, appropriate labeling. The other thing that you may do in an educational in-service, it's required about medication error reporting. All right, it's mentioned multiple times that there has to be some type of system to evaluate medication error reporting, and the way we do that medication error reporting is through MedPass observation. So you may do a nursing in services about, maybe you find in your MedPass observation people aren't using inhalers appropriately. And so maybe you do an in service on how to use the different types of inhalers. Maybe you see that there's a deficiency in several areas, such as appropriate use of eye drops. For example, are they waiting 5 minutes between each eye drop? So when you do a MedPass observation, all right, you want to make sure that you're identifying what's wrong, and sometimes the best way to correct those problems, besides going to that individual nurse, is maybe just doing an in-service for all the nurses. All right, So one of the things that should be necessary too, that's in FTAG 425, is you want to have a communication process for improving, quality assessment, and as I said before, usually pharmacy will have to attend the quality improvement meeting. That meeting has to be at least quarterly, but it can be on a monthly basis. And the biggest thing you are, if you're the consulting pharmacist, you're representing that pharmacy, and you want to be able to do that. You know, this is just some other examples of where communication is necessary, talking about, issues with FTAG 429 and 425. So, one of the things you want to think about if you are the pharmacist is how would you communicate these? What's the best way to do that and develop that relationship? I provided numerous resources online for you, but here's some other links that will help you about the nursing regulations. But let's take a look at some of these samples. We'll step out here for example, take a look. So for example, one of the things periodically that has to occur is we do a MedPass observation. And so usually what happens in a MedPass observation is you'll follow a nurse during their MedPass, and you'll write down who the resident is and if there's a medication. And when you step down here, here's some observation codes. So for example, eye drops not instilled to make full contact with the conjunctival sac. If it's, they didn't flush appropriately, if it was a G tube or NG tube, injections were drawn up inaccurately, insulin suspensions were not used appropriately. The biggest thing too is when a med pass occurs, things that have to be done are the following. Was it, is it the right resident? Is it the right medication? Is it the right dose? Is it the right dosage form? Is it the right administration procedures? And so if you notice that if there was any type of error, what you do is once you are finished your med pass, you add up those errors and you look at the total number of doses given during that med pass and the total number of errors. And if this is greater than 5%, this is unacceptable. And the facility could be fined, add a survey, and this is where you would identify where places we may need to do in-services. Another place that you need to that you would be overseeing, it may not be you directly doing it, but it may be your technician doing this, is there should be a med room inspection, looking at the storage, the cleanliness of the room, looking at the temperature of the refrigerator, looking at making it seem like there's high humidity, is things appropriately labeled, are everything in date in the emergency kits, in the carts. Are they also recording, monitoring appropriately certain things such as blood glucose machines? Is the documentation there for how they order and receive medications? You look at the cleanliness, the storage, appropriateness of the med cart. So you guys can read these upon yourselves, but once again, if there's any additional comments, these are considered irregularities also and have to be reported on monthly basis to the Director of Nursing to address that. And then finally, the last thing I want to talk about is pharmacy reporting. And so if we step out here, I provided you, there's numerous different types of software out there. MHA, which is a pharmacy buying group, they actually provide to pharmacies that belong to it access. They have to pay for it, but there's a system out there called Our Expertise, and Our Expertise actually is a computer documentation system that you can actually keep track of each resident, what medications they're on. Are they on any unnecessary medications? So, for example, they're on an antipsychotic or they're on a benzodiazepine. You can keep track of when you want to recommend dose reductions. You can also then, set up your notes, so so you can have notes, and you can document what type of notes. So maybe it's a formulary management, maybe it's a progress note, maybe it's a note that goes to the physician, and you can directly make those directly to that. I'll let you read through this, but I just want to talk about some of this is a listing of the different type of reports that are there. The biggest, most report that you're going to do every month is you're going to do the report to the individual physicians if there's any irregularities. You may have some progress notes that go into the chart, and then you should have a summary of those irregularities. The other thing is you need to track how many people are on certain types of medications. So, for example, here is a here's a sample report of your recommendations. And so this is something you would give to the director of nursing. So it lists every resident that you may have given a recommendation, and then there's a way that that director of nursing can see, did that physician recognize that note, and were there any changes in that note. All right. You can also have, interdisciplinary notes, but I'm going to slide down here. The other thing is it will generate notes. So, like if I find that there's something, of irregularity, it'll say, "Dear Dr. So and so, resident has an order of simvastatin 80 milligrams. Recent labs show lipid panel within normal limits. Please consider a dose reduction if appropriate." You may even put more elaboration how simvastatin 80 is not appropriate. And if you notice, here's your name. You would sign the note. You would put it into the appropriate place for the physician to see. There's also a place that they could actually fax that back to the pharmacy. You may even put here your contact paid, phone number, and then they can check off if they agree with it. Then they actually nursing can use this as a written order, or especially if you put exactly what dose you want to reduce it to. If they disagree, they can then also document down here why they disagreed. Okay. The other thing I'm going to skip. There's lots of different example of notes, but what I want to skip down to is the other thing that you have to do besides your notes is, sorry, that's taking so long, is that you have to track who's on what type of drug. And so for example, one of the things that the software will do is, and there's numerous different types of consulting software out there, and they'll do the similar things, is you have to track, antipsychotics. You have to track, are they appropriate doses for geriatric patients? And so what you will do is you'll write your progress notes based on that, but you can keep track of labs in this software system. You can keep track of doses reductions. The other thing it will do too is it will give you stats of things that you did. All right, how many drugs that you discontinued, how many drugs were reduced, how many drugs were on black box warnings. You can do economic impact reports. One of the things that should be required every month, though, you should have an executive summary of exactly what you did at the facility, so that can type up your executive summary. You can also give them the detail summary report I showed you earlier of what you did for each resident, so nursing can track that. The other thing that it'll do is you can track statistically how many people are on each benzo. And I'm losing track here. I apologize. Here we go. There is a report that will show how many residents are on different types of inappropriate drugs that we have to track, like antipsychotics, anti-anxiety drugs, antidepressants, and you compare them. What is their center average? You compare them to what their state average, what their national average, and those state averages, national averages come from what's called Oscar data, and that Oscar data is usually updated within the software system. So this is just a brief summary. Like I said, this is not the most exciting lecture. In fact, it's probably good that this lecture is now taped, but this is a very important lecture. And so next week, when we do talk live, we're going to go about the quality indicators. The quality indicators kind of tie into all our regulations and show how nursing's regs really affect pharmacy regs. And we're going to use the case that I posted this week as our guide to do that. All right. If you have any questions, please feel free to email me, and I look forward to talking to you guys next week. And I'll send you out an announcement ahead of time, and I'll also send you an announcement right before we do the lecture for the link to go get into GoToMeeting. All right. Thank you, and have a good